Okay, welcome everyone. Tonight's webinar is on report writing again. I have some images. We'll discuss them and come up with a report impression, ultrasound impression for those images, and discuss those findings, how we analyze the images to come up with the impression. So before I start, because everyone is doing shoulder a lot more than any other body region, I'm going to just talk a little bit about the shoulder area. Because some people are having some difficulty scanning supraspinatus, infraspinatus. So just wanted to reiterate some points, and I have been using these slides in the past as a webinar and also during the modules. So on the lateral side of humerus over the greater tubercle, there are three facets. There is superior, middle, and inferior. And here, as you can see, the supraspinatus mostly attaches on the superior facet and infraspinatus attaches on the middle, but they do have an intersecting region. So there's a region where there's a crossover. So if you're scanning supra and going from supra to infra, there will be a region where you will not be exactly long on supra or exactly long on
Mohini,
infra.
I cannot hear you at all.
You cannot hear me at all? Anyone else?
I can hear you, Mohini.
Okay.
I can hear you.
I can hear you.
Okay, Ganesh, maybe try reconnecting. Oh, he cannot hear me. Why am I saying? Can someone send him a text? Or...
I'll tell the Ganesh. I'll tell.
Okay, he just texted here, so let me send him a text. Okay, all right, so I just sent him a text. Let's go ahead with that. Everyone else can hear me. So, okay, so there are three facets: superior, middle, and inferior. And so supraspinatus on the superior facet, infraspinatus on the middle, and teres minor is on the inferior facet. And this is the area where there is crossover. So as you move, when you're long on supraspinatus and you are going from anterior to posterior to check the entire width of the tendon, you will see that you can see supraspinatus fiber nice and clear. And then as you're going posteriorly, there will be a region where you will not see nice parallel arrangement of collagen fibers. But this region is going to be more like diffuse, will give you appearance which is more seen in tendinosis, because you will not see the parallel arrangement of the fibers. And so is true for infraspinatus. So when you're scanning, you want to make sure you're going from anterior to posterior, and especially when it's a normal study, make sure you're not getting the only image of the long axis at this junctional area where there is crossover of the fibers. So here, going from anterior to posterior, so right after the long head of biceps tendon, you start to see the anterior portion of the supraspinatus. And as you go posterior, you can actually scan the entire posterior cuff in one sweep, going from supraspinatus anterior portion to posterior, and then anterior portion of infraspinator to posterior. And then from there on, you will see teres minor attaching on the GT. So that's the last attachment of a tendon on the greater tubercle. So you can check teres minor also as you are scanning infraspinatus in long or short. If you keep moving inferior or distal on the posterior aspect of the GT, greater tubercle, that's the area where you will find teres minor. So just know that this area can be confusing, especially in the beginning when you are just starting your shoulder scans and you have scanned some shoulders and maybe some normal cases where you were not expecting supra to be abnormal, and you find this abnormality. That means you're not exactly purely on supra fibers. You have some infraspinatus coming from the posterior side. So let's look at the next slide. So this is the cadaver image. So this is anterior here on the right, posterior. medial on the top, lateral on the bottom. So this is medial side, this is lateral, anterior, posterior. So going from anterior to posterior, that's the entire cuff. I mean, of course, excluding subscapularis. So we're talking about 3 tendons of rotator cuff: supraspinatus, infraspinatus, and teres minor. It is mostly a continuous cuff. It's a continuous cuff over the greater tubercle, and there is blending of some fibers. So you will not see a clear distinction where supra ends and infra starts. And this can be challenging or difficult in the beginning when you're scanning the shoulder and not getting your perfect bird beak view for the supraspinatus. So try to get an image of supraspinatus where you see fibers parallel, and you also want to see the rounded humerus and the greater tubercle as a beak. So the beak is because of the rounded portion of the head and the greater tubercle. So you want to see this bony anatomy, bony landmark underneath this supraspinatus, and you want to see the area where your long axis is aligned along the fibers of supraspinatus. That's where you have a good image of supraspinatus. And of course, when you're doing long axis, especially when you are doing it on a patient and you want to find if there are any focal defects, you don't want to just get one image where you get perfect supraspinatus long axis view. And you may, because in that patient you may find some focal defects more posterior or more anterior. Now the entire cuff, not entire, excluding the subscapularis, so 3 tendons: supra, infra, and teres minor. Going from anterior to posterior, this entire attachment is approximately 4 centimeters, 3.8. Plus minus, there are standard deviation of 1.1 centimeters, so it can be 4 centimeter wide or in length from anterior to posterior, and medial to lateral, the footprint is 1.5 centimeter. So it's quite a bit, enough area for you to examine from going from anterior aspect of supraspinatus to all the way posteriorly over the teres minor distal end. But you have to evaluate this as an entire cuff. Just know that it's a continuous structure and the fibers blend, so you don't have a clear defined end of one tendon and beginning of the other. It is a continuous structure. Any questions so far on the footprint or the attachment of supra, infra, and teres minor? Anything from any questions? Maybe some case that you recently, any recent patient that you scanned and you had some trouble, and maybe it's ringing a bell. No. All right, so I'll move on to the next one. So when you're scanning shoulder, rotator cuff, and you're looking for any tendon defect or tendon pathology, which can be tendinosis or partial tear or full thickness tear, there are some important points that we are looking for. So first is we are trying to define what's the degree of tear, if there is a tear. If there's no tear, then you say, okay, it's a normal tendon, no focal tear or any focal defects. Then there may be some other problem, maybe fusion bursitis, tenosynovitis, or maybe a joint pathology, not so much of tendon. But if there is tendon pathology and one of the tendon of rotator cuff is involved, you have to define what's the degree of tear. Now, there are different classification that you can use, but with ultrasound, the one that is more, you can define the tear better is the Southern California Institute classification, which we use, which is defined by the location, which means you're defining it, is it articular sided or bursal sided, intrasubstance. But there are other classification, and most of them are used MRI, and there's a reason why we don't use different types of classification in ultrasound, because we don't see this the portion of the tendon which is hiding under the acromion. So we can better define a tear by its location than the other classification which MRI uses. So we define the degree of tear. You say it whether it's partial or full. If it's partial, you define it whether it's articular side or bursal side. Is it intrasubstance? Is it a complex type, which may be articular sided on the anterior side but bursal side on the posterior side? Then you try to define the size. You put the calipers and see the focal defect. Sometimes it's very well defined, sometimes it's not. So we try to define the size and the degree of tear. If you see retraction of fibers, you can measure that. So you measure how far back the tendon stump is retracted. So you measure that. You may comment on shape. Now again, these are the classification which are used in MRI when you grade the rotator cuff tear based on an MRI, because there is no limitation of posterior shadowing by any bony landmarks, so they can see it much clearer, especially in full thickness tear. So they can define it by its shape, like crescent, U shape, L shape. It's supposed to say L shape. So I'm going to cover this more in the upcoming module, which is after module A and 2A and 2B in the mentorship fellowship. But you can further define the shape also. Not always possible, but sometimes you can see whether it's a U shape or L shape full thickness tear. Now, after that, you may define whether muscle and tendon is the quality is good or bad. Again, there are different classification for tendon and muscle quality. Now, with ultrasound, the best approach is to do side-to-side comparison. So you check the muscle on the asymptomatic side versus symptomatic side, and see how much of what is the if you see any atrophy, what's the echogenicity of the muscle. So you may also check for tendon and muscle quality. And in tendon, so let's say if there's partial tear, you will define the partial tear by the degree of tear and size, and if there is any retraction. And the remaining fibers which are intact, you can comment on that, whether those fibers are healthy or they show tendinosis or inflammatory pathology. So these are the important details that you can provide when you're writing an impression for rotator cuff tear. Now again, reviewing it, I have presented this multiple times, and I'm sure some of you know these slides very well now. So with ultrasound, we use the classification which is defined by location. So whether the tear is more on the articular side of the supraspinatus or bursal side. So this one is articular side because this is closer to the articular joint level. Here is the cartilage, articular cartilage, head of the humerus, that's greater tubercle, supraspinatus, bursal sided fibers intact, and deep fibers, which are articular side fibers, are torn. So that's a focal defect on the articular side. Bursal side tear, so this is focal defect on the bursal side. The articular side tear fibers are intact. And of course, we confirm everything in 2 planes, so you confirm that in 2 planes. Now, third is intrasubstance. So you see focal defect which does not communicate on the articular or the bursal side, and that's intrasubstance. Now, partial tear can be a combination of all 3 of them. So it doesn't have to be a textbook like clean, articular sided, or bursal sided. Sometimes you may see a combination. So here, for example, you may see focal tear here, which is communicating to the articular side, and on this side, posterior side of the supraspinatus, you may see the tear communicating on the bursal side. So now this would be a complex partial tear where anterior portion is articular sided tear and posterior portion is bursal sided. So this is still partial tear, but it's a complex partial tear. Again, if you define it by location, you are giving a good idea about what's the degree of the tear. And if you see focal tear nice and clear, like in this case, you can put calipers and you can measure approximate dimensions of this focal defect. So you'll put one linear caliper right here and one linear caliper here, and you can measure the length and the width. Full thickness is when you don't see anything attached to the footprint here. So like in this case, we don't see the tendon attachment at the GT, and you can see focal defects here, irregularities, and you can see the focal, no tendon visible here. And what's that sign? Someone answer this question. What do we call this sign?
It's a Barsha.
What's that?
It's a Barsha.
I don't hear it very well. Say it one more time.
It's a Barsa, it's inflammation.
Oh, no, it's not bursa. So it's, if you look at this, that's a round part of the bone, right? So that's humeral head. This is GT, which is where shows.
Sign, capsule or?
No, that's a cartilage.
Cartilage.
But if you see, cartilage is showing a rim here, hyperechoic bright rim. Okay, so I think somebody raised the hand here. Vicky, maybe you're muted. Okay, I unmuted you, Vicky.
Thank you. I said halo sign.
No, that's cartilage interface sign.
Cartilage interface sign.
Yeah, cartilage interface sign. So what's happening here is you don't have the tendon, and now there is less impedance to the transmission of ultrasound beam. So articular cartilage, which is supposed to be anechoic or hypoechoic, now because there is no intervening tendon and fluid transmits ultrasound much faster, so we're getting more echo back from this interface, cartilage interface. So it's called cartilage interface sign. So this articular cartilage is showing a hyperechoic bright rim on top, as you can see there. Make sense?
Yes.
Okay, yeah, all right. Okay, so that's cartilage interface sign, which is another indirect clue or indirect sign that there is no tendon above that cartilage. So there is no tendon in this area. There is some fluid, and that's the bursal lining. So here, that's skin, subcutaneous tissue. That's the muscle, deltoid muscle. That's bursa, fluid, and the cartilage. And this is bony interface. So you're getting this bright line over the articular cartilage because there is less resistance or impedance to ultrasound beam. So you're getting the cartilage is sending more echo back. So you're getting more echo from the rim.
Mohini, if the tear is old, like really old, does the space sort of fill up with like fat or
fibrotic tissue? Yes, scar tissue.
Fibrotic tissue, yeah.
Yeah, granulation tissue. Yeah, it does. Yeah. So then, right. So here, like you're seeing, no tendon and there's fluid. Yeah, over the period, if you see this patient maybe like after 6 months or something, you will not see such nice clear view that there is no tendon here. You will see some like fibrotic tissue in this area. Yeah.
Yeah, I think the majority of the people that I scan, really those tears are really old, and initially that's why I had a lot of trouble seeing it, because it was kind of filled up with that fibrotic tissue.
And also over the period, this interface that you see here, that's the bursa, right? This bursa also thickens, and bursa thickens and herniates into the space, so gives you illusion that there is maybe some fibers intact here. Right now it's lifted up because there's fluid here. But over the period, if this bursa becomes thickened and you don't have as much fluid, you can see that this tissue can fill up this defect. So that's when we see bursa herniating into the defect.
Thank you.
Okay, let's go next. All right, so before we move on to the images, cases, one more thing. So this is full thickness complete tear because there's no tendon here. There's one more category where you can get full thickness, but it may be incomplete. So focally, let's say this portion of the tendon was intact and this portion is intact, but in the middle, the entire articular to bursal to articular side is torn. That is incomplete full thickness tear. So when we say incomplete full thickness tear, that means some portion of fibers are still intact, but focally at a certain location, entire bursal to articular side of the fibers are torn. Make sense? So if you think like, there are, let's say there are 10 tendon fascicles attaching to greater tubercle. So that's the long axis. In short axis, actually, let me go back and I think it's going to make sense here. Oh, right here. So this is supraspinatus, right? So let's say there are 10 fascicles. So if we count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, from here to here, 10. Now from 4 to 6 fascicles are completely torn. So they are retracted medially. But 1 to 3 and 7 to 10 are still intact. So, if you divide tendon like that, so in this area, which is between 4 to 6, those tendon fascicles or tendon attachment at the footprint is completely retracted medially. That would be a focal incomplete full thickness tear. It is full thickness, but it's focal full thickness. Make sense? Yeah, this tear is confusing, especially the terminology, because full thickness sounds like something really bad, but this is not that bad because there are still some fibers intact on the other portion of the tendon. Make sense or not?
Can you explain the difference again? Focal,
Okay.
full thickness, and just full thickness.
So one is a full thickness complete tear. So nothing from here to here, nothing is attached. This entire thing is torn and retracted medially. Okay, so
Okay.
that's full thickness complete. Nothing is attached. Now, if this portion, the mid portion of the supraspinatus is torn from, so this we are looking at the width of the tendon, not the thickness, right? In this view, but if you visualize this tendon as a, in the footprint, medial to lateral and anterior to posterior, if only this part, the mid part of the supraspinatus or any part of the supraspinatus is completely torn from bursal to articular side, but focally, but some fibers on the anterior or posterior side are still intact, it's called incomplete full thickness tear. Make sense?
Yes. Thank you.
I don't have image of that here, but I wanted to point that out. But I have that image in the last webinar, and I can, in the next webinar, I can use that slide to help you. Or I can, let me send everyone email, and I'll send incomplete full thickness tear slide one more time. It's different than full thickness complete tear because full thickness complete is more severe than incomplete full thickness. So let me do that after I finish this webinar. Okay, so now let's move to the cases. Okay, so this is a supraspinatus tendon, and you can see this is GT, head of humerus, and that's supraspinatus in long axis view. This is supraspinatus in short axis view, and the red arrow is pointing at focal hyperechoic structure in long and short axis. So what do you think we are looking at? What pathology?
A calcific deposit?
Yeah, that's right. Calcific deposit, and the tendon also does not look normal, right? You don't see normal bright hyperechoic parallel arrangement of collagen. So let's formulate an impression. How would you write this one? Let's say this is what you see in short and long, and you do dynamic tests, and Now you know there is deposit in the supraspinatus, and you're also looking at the fibers, and they're not, they don't look healthy, normal echo pattern.
There's sonographic evidence of hyperechoic signal within the tendon of the supraspinatus, indicative of or suggestive of a calcific deposit, period. And then additionally, there's loss of normal echotexture of the supraspinatus tendon.
Which is suggestive of?
Suggestive of
Incomplete tear.
So let's say let's say we don't see the tear. I mean, it's possible that there is tear, but it just doesn't look healthy, right? So it looks there's hypoechoic diffuse signal, hypoechoic diffuse signal, and there is loss of normal echotexture of the tendon. So that's more of inflammation, degeneration or inflammation, right? So you can measure this calcific deposit. So don't forget that, okay? You can always put the caliper in short and long axis and measure approximately how big is this deposit. Sometimes they are diffuse, but most of the time calcific deposit, when you see, if they're not amorphous, you can see, I mean, this is also amorphous, but you can put some caliper to get some approximate dimensions, which is also good if you're doing a follow-up study and you want to make sure that this patient is improving over the period. I think Brian last year did a very good case study, case presentation, and he had a great case where he did series of ultrasound exam over the period of 1 year, and there was significant difference in calcific deposit. So there was complete resolution with at 9-month interval. So you can measure the calcific deposit. So yeah, so you're right. So you can say there's hyperechoic area, a focal hyperechoic area. You can define further where do you see that hyperechoic deposit. You can say, okay, this is anterior aspect of supraspinatus tendon, and this deposit measures whatever 2 by 3 by 0.5 millimeter or whatever the dimensions are, which is suggestive of calcific deposit, and the tendon appears hypoechoic with loss of normal fibrillar pattern, suggestive of partial tear or inflammatory process. So sometimes tear and inflammatory process is difficult to tease out, and it's okay to say this can be this or that. If you look at other imaging reports like MRI, X-ray, they also make some suggestions based on what they're seeing. So, you know, no imaging technique or modality is diagnostic of anything, right? So we look at the grayscale images and we try to interpret those based on the clinical presentation or physical findings, and try to determine what kind of problem this patient is presenting with. So there's always clinical correlation. And sometimes pathology is not like black and white. Especially when you're looking at some type of inflammatory or tendinosis with focal tear, partial tear, it can be sometimes difficult to say definite, okay, it's just a partial tear or it's just inflammatory process. So it's okay to say and or in those cases. So this is how you would say there is a focal hyperechoic area in the anterior aspect of supraspinatus tendon, measuring 2 by 3 by 0.5 millimeters, suggestive of calcific deposit. Supraspinatus tendon appears hypoechoic with loss of normal fibrillar pattern, suggestive of partial tear or inflammatory process. So that was
on the short axis view, Mohini, it doesn't look like a retracted segment of the supraspinatus.
No, it's not retracted. We don't know. No. So partial tear can be. So we're using a partial tear. It can be interstitial focal fiber failure. It may not be like, you know, a significant portion of fibers torn and being retracted. You can have focal microfailures. You can think of it like that. And most of the time when you see some type of tendinosis, there is some type of focal interstitial tearing which is not something significant, but like micro failure of fibers, fiber failure. So we are looking at fiber failure and inflammation going hand in hand.
Okay.
Yeah, and also calcific deposit does not happen in a healthy tendon. There is some type of environment, molecular environment that is set up because of degeneration, microfiber failure, and there are molecular changes like changes in oxygen tension, and that makes the cell to secrete calcium. So if you see calcific deposit, there is some type of degenerative process going on there.
So how do you differentiate calcific deposit compared to a bone spur, since there is no bony cortical irregularities?
Oh, so that's a good question. So here, so you will, okay, let me go back to where there are no markers. So look at the hypoechoic deposit here in long axis, and then look at it in short axis. If this was a spur, you would see it coming off from the bone like a bony protuberance, right? You will not see it as a diffuse cloud. Like this looks like a cloud here, right? Yeah. You will see it more, even in early stages when it's not completely calcified, cartilaginous, you will see a little step off from the bone, and it's not going to be diffuse as big as it is right here. Okay. And this is in the substance of the tendon, right? You will just see it just off the bone as a protuberance.
Mohini, I have two.
Yes.
The first question is, how did you decide, I can't quite wrap my head around, how did you decide which picture you're doing the two measurements and which picture you're doing one measurement? Do you know what I'm asking you?
Two measurement?
Go back to your calipers, the one that has the calipers on it. So in long axis, you have two measurements versus in short axis, you have one measurement. Mm-hmm. I can't quite get that spatially in my brain.
Okay, so so whenever you're measuring any mass, like soft tissue mass, which can be hard or cystic, or so I'm treating calcific mass also the same. You take the measurement in long axis, which will be the length of that structure. In short axis, that will be the breadth of that structure. And actually the height, you can take it in short or long, but here I can see better defined, so I took the height in the long axis view.
That makes sense, because I think I typically measure the height in short axis.
Oh, it doesn't matter. Yeah, that's fine.
And that's where I was confused that maybe I was doing that.
Yeah, height can be, it can be in long or short, but length is in long axis and breadth or width in short axis. Yeah.
Okay, and my second question is, you commented that the focal hypoechoic area is in the anterior aspect of the supraspinatus. Mm-hmm. I think I would have called that proximal. So I'm confused as to if anterior and proximal are both correct.
No, I know why you said that, but no, proximal would be confusing to whoever is reading the report, because proximal, so the fibers are coming towards the GT, right? So those fiber portion, this is distal part of the supraspinatus. This is the most distal part of supraspinatus visible, right? Because then supraspinatus tendon inserts here. You cannot go more distal than that. Proximal would be somewhere up here, if you're saying tendon or muscle. So I don't know why you're saying proximal.
Yeah, I think I had that backwards also in my brain.
So we don't, normally you wouldn't see it in proximal. You would see somewhere in the distal portion of the fiber. So you define it more like, is it the anterior portion? So here, see, this is where the supraspinatus is, anterior, and then this is the posterior portion. And of course, whoever is scanning has to also have the orientation correct to know that. So we know this is distal portion. It's always somewhere in the distal portion of the fibers. But here, the short axis view will tell you, is it more anterior or posterior? Again, it's more, commonly it's more anterior. So you can see this is the most anterior portion. You don't see much. This is not the tendon. This is where the tendon ends. And this is the posterior portion. So if you keep on going, you will see infraspinatus, anterior minor, somewhere around here.
Again, I think I just have it backwards in my head.
Oh, the orientation?
Yes.
Yeah, it happens. Okay, but now you have it right, correct?
Yes, that was very helpful.
Okay, good. So let's move. Can we move to the next one?
Yes, ma'am.
Okay, let's go. So this is, again, supraspinatus. Now here, this is the case where the tear is not acute, it's chronic. So this is these are the cases that you're seeing, Vicky. So I'm just going to tell you this is a complete one. This is the bursa, which is thickened, and of course, you know, the person who's doing it, you may not be able to see this in just 2 images. You will have to do some more imaging, some dynamic testing, because this is confusing for a lot of people. This is bursa. So I'm going to define the top margin, the superficial margin of the bursa. And this is the deeper margin of the bursa. Here, come on, move my, okay, here. This is the bursa. This is the deeper margin of the bursa. This is the top superficial margin of the bursa. Oh, sorry. Let me go back. Okay, here, so that's the entire bursa, thickened bursa herniating into the space. So, so you can see this anechoic area. So there is no tendon here. Then we see some thickening. This can be the capsule, and cartilage is not seen, but it should be somewhere around here. So that should be the cartilage. That's not in focus, but this is some capsular fibers. This is the empty space, and this is bursa. And so is true here. In short axis, you can confirm that no tendon here. That's the bone, and you start to see thickened bursa in this space. So this is the case of some old tear, or maybe not so old, but some type of pathology going on for the bursa to thicken that much. So there is peribursal hypertrophy. So this bursa is hypertrophied, thickened, and it's taking the space and giving an appearance as if some fibers of supraspinatus are still intact, but they are not. And one more thing that you can see here, you see this part of the tendon. Normally, this part of the tendon, this is the rounded part of the beak, right? If you see this flattening, you always question whether some fibers are intact or not. If you see from GT to proximal portion of the supraspinatus bursal lining, if it is more straight over this area, you want to inspect this area very clearly, because most likely this is the bursa herniating into the defect, and there is no supraspinatus attached. Okay, so now that we know what it is, let's try to formulate an impression. And someone raised the hand. Let me see. Brad, I cannot unmute you. I don't know. I don't know if you are connected through phone but it just doesn't give me option to unmute you. So if you can type, I can read it. Okay, while Brad is typing, can someone write an impression for this one? No one? Come on, give it a try.
There's sonographic evidence of anechoic, or no, let's start over. There's non-visualization. There's
yeah, exactly, yeah.
Of the
it's not anechoic, yeah.
Right. I knew what I wanted to say was it's not there, and that's the first word that came to my brain. Yeah, there's non-visualization of the supraspinatus tendon, indicative of a full thickness tear. Additionally, there is herniation of the bursa into the supraspinatus void.
Yeah, that's good. Yeah, and it's herniating into the space because it's thickened, right? So you have to also comment on
due to thickening of the
bursal thickening. Yeah, bursal hypertrophy. That's good. Yeah. So you covered all the important points. So that's good. So yeah, so you'll see, you can start by you don't even have to say focal hypoechoic region. You can just say there is non-visualization of supraspinatus attachment to the, or supraspinatus to the GT, suggestive of full thickness complete tear. So now here this is full thickness complete. That means the entire width of the tendon is retracted or torn from GT, and retracted tendon stump was not visualized. Sometimes you can see the retracted stump balling up here. Then in that case, you can put the caliper and measure the retraction, but sometimes it's not visible because it has retracted far more proximally. So it's, you can say it's not, it has retracted proximally and it's not visualized. And then there is evidence of hypertrophy of overlying subacromial bursa, which is herniating into the tendon defect. So yeah, you covered all the points, Vicky. That's good. Let me see if someone else tried to type. Okay, Brad has some difficulties. Okay, so Brad is saying that he has difficulty with these type of patients, and I know it is convex or a straight line from lesser tuberosity is a problem, but my main clue, lack of seeing muscle tissue striation, fibrillation. So if you're saying lesser tuberosity, I think you're talking about subscapularis, right, Brad? So you, if there is any tear, you will not see the tendon attached there. The best thing you can do is a real-time ultrasound is try to do dynamic assessment. That always helps. Sometimes, you know, you are not clear, and there will be patients because there is chronic cuff arthropathy and you're seeing multiple findings, joint findings, joint abnormality and tendon soft tissue abnormality. And so in those cases, you can use dynamic assessment, can be passive or active, and that helps clarify, you know, how much of it is a bursal problem, or is it effusion, or how much of tendon is still intact or is completely absent. And you also see abnormal dynamics also. You know, when you use passive or active movements, you can see structures are not moving how they're supposed to move. So yeah, make sure you use dynamic assessment. Okay, right. Okay, so this is supraspinatus tendinosis. Because what do we see in tendinosis? We see hypoechoic tendon, hypoechoic heterogeneous tendon. So it's not evenly hypoechoic. It's not, so there are some areas of hypoechoic region, hypoechogenicity or hyperechoic, and we don't see normal fibrillar parallel echo pattern of a healthy tendon. You can also see the tendon appears to be thickened in this portion here. And you can confirm that in short axis, it looks swollen or enlarged. It has lost its normal fibrillar pattern, its normal tendon contour, and you can put the color Doppler here and see if there is any vascularity in this tendon or not. So I have already said all that's wrong here. So now let's try to put it together in an impression. You can type or you can say, but you know, try to give it a try. Just give it a try, because if you don't give it a try, you will not get into the habit of writing your own impressions. You already know what's wrong here. You just have to put those words together. No one?
I feel like I'm hogging it if I say it again.
Come on, someone can try. Now this one is easy. I already said what all that's there to say. You just have to put it together. I want someone to try this one. This is easy. Okay, so I see someone typing. So Ganesh is saying there's evidence suggestive of. No. This is not full thickness tear, Ganesh. This is tendinosis.
There is.
Okay, so give it a try, Vicky.
Okay, there's. Do you say heterogeneous? Is that the way you pronounce it? Heterogeneous?
Heterogeneous, hypoechoic, heterogeneous.
Okay, there's, yeah, hypoechoic, heterogeneous echotexture of the supraspinatus with thickening indicative of tendinosis.
Yeah, so Ganesh, I just wanted to clarify, this is not tear, this is tendinosis, because in tendinosis you see the swelling of the tendon. So tendon is swollen, it's hypoechoic. It's not evenly hypoechoic. You don't see just one gray scale here. You see different regions of different echogenicity, so some hyper, some hypo, and it doesn't have that nice linear fibrillar arrangement of collagen fibers. So this is tendinosis. So this is how you say it. It's just as Vicky said, this hypoechoic heterogeneous signal and loss of normal fibrillar echo texture or echo pattern. There are different ways of saying this. In supraspinatus tendon with swelling or enlargement of tendon, you can say this is consistent with tendinosis, or you can say this is suggestive of tendinosis. And again, when there is tendinosis or inflammatory process, sometimes it's hard to tease out any focal microfiber failure. So focal interstitial tears are possible because you can see these regions, right? This can be just degenerative changes, or it can be focal fiber failure. So sometimes we cannot completely rule that out. And whenever you see any problem like that, you should also always put the color Doppler. If you see vascularity, then you can say you see vascularity on color Doppler, or you don't see it. If you see it, then in tendon it's indicative of neoangiogenesis, or another way of saying it is angiofibroblastic proliferation. So neoangiogenesis is seen in tendinopathy, and so color Doppler will help differentiate that, whether it's present or not.
So Mohini, you're saying that sometimes just the way to tell between the tendinosis and an actual tear is to look for the angiogenesis.
Oh, no. Sorry. No. I'm just talking about all findings. No, with angiogenesis you cannot find the tear. But so when you put the color Doppler here, you will see the evidence of neoangiogenesis, or whether the tendon is trying to like heal itself, which you see in tendinopathy. It can be tendinosis without tendinopathy. So you just have to mention whether you see that physiological information with color Doppler or not.
Okay.
When you,
I'm a little bit with Ganesh though. I would have a hard time differentiating between that being a tear and being tendinosis.
This is definitely tendinosis, but this can be a combination of tendinosis and tear.
Yes.
It can be a combination of both.
But it's not a full thickness tear.
Because tendinosis, you do see tendon swelling, which we are seeing here. Right? When there is tear, you see thinning of the tendon. When you see tendinosis, you will see thickening of the tendon. So we are seeing swelling or thickening of the tendon, or enlargement of the tendon. Look at this area in short axis compared to adjacent, right? Look at this area here.
Yeah,
So,
I think that helps.
Yeah. So you will look at the tendon qualitatively and quantitatively. Now, the second point, if there is focal tear or not, sometimes you cannot differentiate that. So you can say, okay, there is possible that there are some interstitial tear which you cannot differentiate, like this area here, right? Or this area here. But if you put the color Doppler, and you see vascularity here and here, then that's angiogenesis. You're seeing some blood vessels. This is not focal tear.
Yes, I understand.
So I'm just trying to say that it can be a complex picture where there are multiple findings, and you cannot define it black and white tear and tendinosis.
So Mohini, how would you differentiate a bursal thickening or in herniation of the bursa compared to tendinosis where there is inflammation within the tendon? Because both looks the same.
Yeah, so here, remember that image I told you, like this area was more like flat, not so rounded.
Yes.
Right. So so think of it like as different interface. So going from skin to deep to bone. This is skin, subcutaneous tissue, deltoid, bursa, tendon, and bone, right? So bursa has muscle on top and tendon in the bottom, right? So if you take one layer out, deeper layer, this will deflate, right? Like let's say you can fill the air here. The air is the tendon, and this is all like rounded here. But if you take this interface out, or some fiber of it is out, this becomes more flattened, right? Do you remember the first case, like last case I was telling you? If you see, okay, let's go back there. Remember I was telling you if you see this part, the bursa, which is from GT to proximal, if it's linear and flat like this, you're questioning whether the tendon is intact or not. See the bursa here? So this is muscle, right?
Yes.
Right under the muscle is the bursa. So this interface is the bursa, and it's flat. It's not rounded, right? And see, even in short axis, can you see how flat this is? It's linear. It's flat. It's flat here. And now let's go back to this one here. See how this is rounded, and bird beak view is rounded. So I don't think it's gone. The tendon, it's still there, although the tendon doesn't look healthy. Make sense?
Yes, but the slide on the right side.
This one?
That's still the round, because the round shape is
Yeah,
intact.
you can see the round shape here, right?
Okay, yeah.
So just think, the filler is still there, whatever is filling up. So if this is the membrane or a thin think of it as a thin fabric. So this is a fabric, and there is muscle tissue on top and tendon tissue in the bottom under the fabric. And if you take this tissue out, this fabric will become flattened, right? But if you put this tissue under the fabric, it is going to stretch it out like that. Make sense? I just came up with that.
Yes.
It was good.
Okay. Yeah, I'm a visual learner, so I like to use these examples. Okay. Now, are we all good? Can I move to the next one?
Yes.
Oh, actually, before we move to the next one, so let's look at this one more time. So that's why we said it's hypoechoic, and it's not evenly hypoechoic. So heterogeneous signal, and it's not normal looking fibrillar ecotexture. It's swollen, and it has lost its normal fibrillar ecotexture, and you see the focal swelling, and you may or may not see vascularity. Okay. All right, so now we go to the wrist. So this is a cystic mass on the dorsum of the wrist. This is long axis view. This is short axis view. And you can see the cystic mass. This is radius. This is proximal carpal, distal carpal. And this is right over this area. So what is it?
Are you saying write the impression from that?
Yeah, no, before you write the impression or say the impression, what structure is this? What abnormality? What pathology is this?
Ganglion cyst.
Okay, good. All right. So just wanted to get that right. So you can measure it, right? So you'll put one caliper from here to here, here to here. So this would be the length. This will be the breadth. And height, you can get it from long axis or short axis, because height is, you'll get approximately same dimensions in both. So can you formulate an impression for this one?
There's a hypoechoic signal in the, you said radius. I would say where it was between the radius.
You can say dorsal aspect of the wrist.
Okay, dorsal aspect of the wrist, indicating a ganglion cyst, measuring whatever by whatever by whatever.
Yeah.
Indicative of or suggestive of a ganglion cyst.
Yeah, that's good. Yeah, Yeah, this is what you write. So you covered all the important points. So you can say there's a localized region, anechoic or hypoechoic region measuring 3 by 4 by 1 centimeter on the dorsal aspect of the left wrist, suggestive of cystic mass or ganglion cyst. Both are correct. Now you can go further, define the cyst, which is not always possible, but sometimes it's possible. Can you see this? The root is going towards the radius.
Yes, I was going to ask about that.
Okay, yeah, so you may not have the clear visualization of the stalk or the neck of the cyst, but sometimes you do. So if you do see that, then you can go on to define it a little bit more, that okay, that you can see the neck or stalk of the cyst coming from the radiocarpal region, so it's likely a cyst arising from distal radiocarpal joint. Sometimes it can be, you know, like mid-carpal row or scapholunate interval. So then those are like extra additional. But so most important is you define it as a evenly anechoic or hypoechoic structure, which is on the dorsal aspect, and it measures so and so, and it is a cystic mass. So that's the important thing with ultrasound. Ultrasound is great in differentiating solid from cystic. So we have to define cystic versus non-cystic.
Okay, and I have a question about that.
Yep.
The cystic mass, when it's cystic, it always has the posterior enhancement, correct?
Yeah.
Versus if it is a solid mass, it will not.
No, there are exceptions.
Don't confuse
There
me.
are some solid masses which will give you some posterior enhancement. And now that depends on the cell type. So if you remember your great case of schwannoma will
Yes.
show some posterior enhancement, and that's why it can be confused with cyst. I had a case where there was a mass on the 5th digit, and that was a schwannoma. It was confused with a cyst based on MRI. So before I did the ultrasound, somebody did the MRI of that region, and they thought that's a cyst. And then the surgeon attempted aspiration based on that. So yeah, and yeah, that was solid. So you know what you have to do? You have to scan it, go proximal and distal, and see. So that mass was continuous with the ulnar digital nerve. And that's how you say whether it's a cyst or not. So not just the echo texture. So, you know, it's of course, if it's anechoic or hypoechoic, you know this is a cyst. But you also have to see where it is. If it's continuous with the blood vessel or a nerve, then you may be looking at something else. So don't just look at the echo texture. You also have to see which body part, which region it is. And you have to clinically correlate it with patient's finding. You know, slow developing, is it something that is sudden onset? So, you know, those other findings.
When you see the schwannoma like that, because I know in the case that I saw, do you always have, you know, mine had a lot of angiogenesis going on in it. Is that another cardinal sign of a schwannoma versus?
That is so that's a good sign to differentiate solid from cystic. So if you see vascularity within that mass, then that's not cystic, then it's solid.
Okay.
Yeah, but now, okay, so now after, so let's say you found a mass which is hypoechoic, and you're not sure if it's cystic or solid. Now you put the color Doppler, which you did, second step. Now you see vascularity in that. That means it's solid. It's not cystic. So that's settled. It's solid. Now, after you establish that solid, you can scan, move proximal and distal on that mass to see if it is attached to something. And if you see this mass attached to a nerve, then you're looking at a nerve sheath tumor or nerve tumor. But if it's not, then you're trying to look for if there is any adjacent joint or tendon sheath, because if it's a mass originating from soft tissue like a joint or tendon, then that's the source of that growth. So most common one is giant cell tumor, which you see around the joint and the tendon sheath or joint. Make sense? Okay, so I think Brad has been writing some impressions, which is good, Brad. I just saw them for the supraspinatus tendon previously and the ganglion cyst. So he's saying there is evidence of large hypoechoic area on the dorsum of the wrist that is consistent with ganglion cyst. And the stalk appears to be coming from radial carpation, so that's good. And Andy said, can a cyst be slightly compressible? That's correct. That's another thing you can do. So if you are differentiating cyst from solid, you can compress, do a little sonopalpation, and if you can displace the fluid or compress it a little bit, it's more cystic versus solid, which you cannot compress much. But there are certain exceptions, especially like ganglion cyst and dorsum of the wrist. There's a lot of pressure in this cyst, so you may not be able to compress it much. So the fluid does not go that much into the joint. So like for example, the suprapatellar bursa, you can compress it and you can move the fluid because it's a big cavity. It communicates with the joint. But dorsum, wrist, ganglion cysts are very hard because they have, it's not clearly understood, but they have this valve like structure at the neck and stalk. So the flow is in unidirectional. So it doesn't go back as much into the joint. Okay, so there are always, nothing is absolute in ultrasound, so there will be some exceptions, but just know that everything is a grayscale. So whatever you're looking at, it is grayscale now. So we cannot assign a specific scale, anechoic or hypoechoic, to a tissue, because it's based on physics how much a tissue is reflecting that echo back, and that can change whether that structure is normal or abnormal. Make sense?
Yes.
Okay. Yeah. So it's good to know like some general principles and what generally a tissue is. Like we know bone is hyperechoic, muscle is hypo with hyperechoic fascicles, tendon is mostly hyperechoic. But after that, once you know like general sonographic appearance, try not to be so rigid, fixed in your thinking that you should always see tendon hyperechoic and bright, or muscle as hypoechoic, because it depends, what structure is on top of it and what type of pathology you're seeing. Okay, I think I'm going to end right here. If you have any questions, you can ask them or you can type them, and I'll see you again next month.
That was good and helpful.
Okay, thank you.
Thank you.
Thank you.
You're welcome, everyone. And have a good night. I'll see you next month.
See you next month. Thank you.
See you next month.
See you next month.